Welcome to this myelodysplastic syndrome, or MDS Phone a Friend series, where you'll have the chance to listen in on your peers discussing common clinical challenges in the management of lower-risk MDS-associated anemia. Check back frequently to tune into episodes in the series that cover topics such as diagnosis and classification of MDS and management of patients with lower-risk MDS who would benefit from an individualized approach to pharmacologic treatment. Today, Dr. Andrew Kuykendall is getting ready to see Bill, a patient with lower-risk MDS and symptomatic anemia who has failed treatment with an erythropoiesis-stimulating agent, and he has some questions for his colleague, pharmacist Alyssa de Castro.
Hey, Dr. De Castro, it's been so long. I haven't seen you since Iowa. Thanks so much for taking my call. I did want to tell you about this patient I had. So his name's Bill. He's a 77-year-old guy. He's got a history of hypertension, hyperlipidemia, type 2 diabetes, and he's got this 5-year history of low-risk myelodysplastic syndrome, or MDS, with really isolated symptomatic anemia. He came over to me from his community hematologist, oncologist, just to get a sense for continued management and get some assistance from that standpoint. So his bone marrow biopsy showed 80% cellularity, had some dyserythropoiesis, 10% ring sideroblasts, and 2% blasts. He did show that he had an SF3B1 mutation. And he's really been getting some red blood cell transfusions pretty consistently, on average about 2 units or so per month. He was on darbepoetin alpha 6 months ago was when this started, and really it didn't really change his hemoglobin too much, even though the fact that we kind of ramped it up all the way to darbo like 500 micrograms subcutaneously per week. His serum EPO before we started the darbepoetin was actually 495. Any thoughts from your end on what led to this kind of Bill's lack of response to the darbepoetin? I know, we were expecting to see good things, and really the hemoglobin didn't budge at all. So any thoughts from your end on why we didn't see any response there?
Hi, Dr. Kuykendall. Thanks for calling. It's actually very interesting. I've noticed that a lot of patients that have really negative response are those patients with endogenous serum EPO level. They're mostly high, so above 500. Or sometimes patients also who have a high red blood cell transfusion requirement. So like, for example, if they get at least 2 or more than units per month, usually they typically do not respond better with ESAs. Also, good thing to worry about is that if patients have low-risk MDS and they have deletion 5q, those are people that have unfavorable response. And sometimes some providers use the high red score, which usually they factor in your hemoglobin and some erythroid markers such as CD36 and CD71. So looking at those factors together can show us that it could be an unfavorable response. For some people, they could have some favorable response. So if they have a blast count of less than 5%, they do pretty well in those patients. And obviously, patients that have good IPSS score, so anything 1 or less, most likely will do better.
So I guess when thinking about this, what criteria should I consider? What criteria need to be met? In someone who we do give an ESA to, who has low-risk MDS, how do I know how to define them as not responding or non-responsive to this therapy?
That's a great question. So there's actually 2 types, right? So there's a primary refractory to the response. And these are the patients who treated with ESA and they are resistant from the get-go. Or those are patients that do not respond after 8 to 12 weeks of ESAs. So some patients do get G-CSF as well, just to help with the, neutropenia. So those are the primary refractory patients. For the secondary resistance patients, these are patients that actually previously did well with ESA and they had initial response close to the median of 2 years, but then out of nowhere, they stopped responding. Or after the loss of their response, they look at their disease and they didn't see any other additional cause of anemia. So those are considered to be your secondary relapse per se.
I got you. So I guess what what other therapies do we have in patients that really are refractory to ESAs? I mean, talking about this low risk MDS population, are there any other options of therapies that we have for those folks?
So we are actually very limited to what we can use for these patients. As of right now, there's 3 drugs available in the market. The one that everyone uses, that all the doctors love, is the luspatercept, right? Because luspatercept can be given as a first line. So even if a patient doesn't have any previous use of ESAs, they can be treated with luspatercept. Also, you can be treating it for patients who still have anemia, and they've been requiring at least 2 red blood cell units for over 8 weeks. And they're failing ESA. So that's pretty much the most indication for luspatercept. For lenalidomide, again, this is mainly for patients with deletion 5q. For imetelstat, which I kind of mentioned earlier, it actually just got approved last month. So this one is more for treatment for patients that are requiring at least 4 red blood cell units, so kind of higher than your luspatercept, over 8 weeks. And it's not also given as a first line. This is kind of more of later on if they fail ESAs. So looking at their dosing, so luspatercept is pretty interesting because it starts as 1 mg per kg, and it's usually given every 3 weeks. Great thing about this is that it's given sub-Q. So patients come into the clinic in and out. What we would do is most of the time, most patients don't respond on the first dose, which is the 1 mg per kg. So we would increase them to 1.33 mg per kg. And usually we would wait for at least 2 doses, which is about a month and a half. And then if they don't do well on that, we can go up to the maximum of 1.75 mg per kg. And again, we always have to wait for at least 2 doses if they don't respond. Lenalidomide, pretty easy. It's an oral drug. We give it 10 milligrams daily. So the good thing about imetelstat, this is kind of the new kid in the block. We would give it also as weight-based dosing, similar to luspatercept, which is 7.1 mg per kg. But it's an infusion, so different from luspatercept, which is sub-Q, and that's given every month. So people usually wait at least 2 hours in the clinic and maybe some infusion reaction after, so it takes a little bit longer, but they don't have to come until next month later versus every 3 weeks. So just quickly going through the mechanism of action of luspatercept and all these drugs. Luspatercept, again, it regulates your erythrocyte maturation. So the main thing is that it binds to the TGF-beta superfamily ligands, which in return kind of like stops the SMAD2 and 3 signaling, and then it increases the amount of the mature red blood cells. Lenalidomide is actually a useful drug. We've done it in myeloma, we've used it, but this is more given for, obviously, for anemia, right? So they would use, is it a direct anti-proliferative effect, which is mainly, again, for deletion 5q MDS patients. And it inhibits the cell division cycle 25C, and it also inhibits PP2A phosphatase. And again, all of this will restore erythropoiesis. And then the last one would be imetelstat. And again, this is kind of new. It is a telomerase inhibitor, which it binds to the RNA template. So it just prevents maintenance of the telomeres.
So when we're thinking about these, I understand. I mean, they sound like really great options that we might have for patients who are refractory to ESAs. But what about side effects? What are the most common and serious kind of treatment-related adverse events, as they call them, that we need to be aware of with these treatments?
Yeah, that's a good question. For luspatercept, the main side effect is hypertension. So we have to keep in mind when these patients have a past medical history of hypertension, we just have to monitor their blood pressure pretty often during this treatment. And if we have to increase their blood pressure medication dosage or maybe increase more blood antihypertensive medication, it might be needed for these patients. For lenalidomide, usually venous thrombosis. So a lot of our doctors, we actually give them some sort of antiplatelet therapy just to kind of alleviate this venous thrombosis risk. So we would give maybe low dose aspirin if a patient can get it. And then for imetelstat, which is funny enough, this is one thing that we worry about, is cytopenias. So a lot of these patients, according to at least the trial, because it's just new, is mostly thrombocytopenia and neutropenia. So those are things to worry about. And also because it's an infusion, a lot of the infusion related side effects as well. So Dr. Kuykendall, just wondering, how would you decide if a patient actually needs hypomethylating agents or maybe even consider allogeneic stem cell transplant if they are lower risk MDS and ESA refractory or has experienced a loss of response to the ESA therapy?
Yeah, it's a great question. Obviously, hypomethylating agents, allotransplant, these are certainly options for patients with myelodysplastic syndrome. And we think about, allotransplant, really often the only curative option that we have for these patients, but, a lot of toxicity associated with it as well. And with hypomethylating agents, these are certainly options as well, but I would say, something that I tend to favor more when we're starting to get in that realm of higher risk MDS or patients with higher blast counts. We've looked back retrospectively at patients that have low risk MDS, and certainly not all of those patients stay as low risk MDS, right? A lot of those times patients can actually progress to higher risk or progress to secondary AML, and that's where I tend to favor using hypomethylating agents is when that disease looks like it's ramping up and moving beyond a low risk disease state. Allogeneic stem cell transplant tend to favor also for the higher risk MDS, secondary AML patients. But also I think it can be an option, especially if you have younger patients with challenging disease, maybe hasn't responded to 1 or 2 lines of therapy. This is something you can talk about as a potentially curative option. Now with kind of newer agents that are there that can help with kind of transfusion requirements, as well as in patients that are requiring higher amounts of transfusions with imetelstat. I think we have a couple other agents that we can use to bridge patients to transplants, but I think it's important not to forget about these options that we have because we don't want to miss the window where we can offer a curative option to these patients.
That's really good to know. It's something to think about, beyond all these drugs that we see. So in your opinion, what would be your preference then for like a second line treatment for our patient Bill here?
Yeah, I think for Bill, based on the information that you gave, and I really feel like the luspatercept agent really makes the most sense for him. As we mentioned, this was a patient that had, relatively modest transfusion requirements, though he was requiring transfusions around 2 units per month. And someone who'd previously been on ESAs still had an EPO level that was less than 500 before going on ESA, although very close to that. But I think that presence of the ring sideroblast and the SF3B1 mutation is really what makes me think luspatercept would be really the best option there. If you look at the Medalist trial, this is a phase 3 trial that enrolled patients with low-risk MDS who had ring sideroblast and really looked at whether or not, or with the primary endpoint, really looking at whether these patients could go from requiring transfusions to not requiring transfusions. And we saw that really with the primary endpoint looking at achieving transfusion independence for 8 weeks or longer, this was seen in more patients on the luspatercept group as compared to those on the placebo group. So actually up to 38% in that luspatercept group compared to just 13% in the placebo group. And then there was actually a key secondary endpoint looking at having transfusion independence for longer than 12 weeks. Now we're talking about 3 months or more. And that was again seen more frequently in the luspatercept group compared to the placebo group. And really overall it looked quite favorable in terms of side effect profile, where we saw really main side effects were things like fatigue, diarrhea, asthenia, nausea, and dizziness. But overall, as patients got further into their therapy, these side effects tended to decrease over time. I think more recently we've actually seen longer term follow-up of that study come up as well. So we have actually up to 26 months of follow-up from the Medalist trial. We're seeing that patients who actually were able to see luspatercept for longer than 2 years were actually able to get to a cumulative red blood cell transfusion independence duration of longer than a year. And so really overall, I think what we're seeing is an agent specifically in this patient population of SF3B1 mutations and ring sideroblast that you're able to kind of drastically improve their ability to have effective hematopoiesis, and really with a safety profile that looks quite favorable, especially when we're talking about long-term treatment. So I guess one question, I think you mentioned this earlier, but one of the things I was thinking about is if I start Bill on luspatercept at 1 mg per kg, when should I expect to see a response? And to that end, when should I think about titrating up?
So I would say that I would at least wait 2 doses. So it's given every 3 weeks. So at least 6 weeks of treatment before you move up to the next dose, which is the 1.33 mg per kg. And then there is a max dose. So the max dose was the 1.75 mg per kg. But usually most of the time we see some response by then.
Gotcha, that's wonderful. So I think taking away some of the key points that I think we've discussed today is that, although ESA therapy can be effective in some patients, there are some specific factors that you mentioned that really can be used to predict a response. And perhaps we should have seen this with Bill, that he had some of those factors that may have predicted less likelihood of a response to ESA. And certainly I think it was very exciting to hear about luspatercept, which is FDA approved to treat anemia in patients who failed an ESA and who are requiring at least 2 units of red blood over 8 weeks. This is approved in low to intermediate risk MDS with ring sideroblasts or MDS MPN overlaps with ring sideroblasts and thrombocytosis. And then I thought what was interesting also, if we're not seeing a response to the initial dose of luspatercept after 2 doses, we can really think about up titrating, first to 1.33 mg per kg, then up to 1.75 mg per kg after another 2 doses in an effort to really achieve those responses in a timely fashion. So thank you so much, Dr. de Castro, for joining us today and really helping me with the care of this patient.
Thank you for having me. I hope it does well with Mr. Bill.
So thank you for joining us for this Phone a Friend program. Please remember to take the post-test and fill out the CME evaluation. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com. And you can view other low-risk MDS Phone a Friends episodes on the series landing page. Thank you.